While the panelists are moving up, I'll take this opportunity to say that it's a great honor to be here among the big stalwarts, and I'm grateful to Dr. Chaudhary for giving me such a brilliant panel. I came to know about the panelists just about a day earlier, and therefore I did not have time to send the questions to them. But I assure you that answers to all the questions have already been given in the previous 2-3 talks. There are 7 questions. 2 of them are audience polls, and 5, one each for you. This is a 48-year-old car salesman who is overweight, hypertensive, has raised transaminases, and a fatty liver on ultrasound. There is no history of alcohol intake or diabetes, but his HCV RNA is reported to be very high. Diagnosis that is closest to what you will write on the prescription is 1. Chronic HCV hepatitis and metabolic syndrome, SE, MASLD and MASLD, NAFLD and HCV hepatitis, MAFLD and HCV hepatitis. Can we have the audience poll, please? Okay. So most people will write MAFLD and HCV hepatitis. Dr. Chaudhary, your audience is very defiant. They are not following your recommendations of the new classification. So we'll go to the next question. These first three slides are basically a repetition of what has already been shown to you. The name NAFLD was coined by Dr. Ludwig, and it will be of interest to you to know that when he initially wrote up this paper, it was rejected by a major medical journal and the working group at Falk Foundation. And subsequently, he had to publish it in the in-house journal, that is the Mayo Clinic Proceedings. And over 40 years, it has become one of the commonest diseases that we come across. In 40 years later, the name was revised, as it has been told to you, and 3 years later, it was revised again. This was the first revision. You all have read about it, so I'm not going to discuss this at all. And this is the second revision, in which I have specifically written there the amount of drinks that are required to be there for making that diagnosis. Less than 2 drinks a day on an average in a male is MASLD. More than 3 drinks a day is MET-ALD. All right. So these are the adult criteria which have already been discussed. Now I'll do the case presentation. This is the second and the last case. And there is a hierarchy in this case presentation. The patient is a medical intern himself who represents the primary care physician. The case is being presented by a DM resident, which represents the secondary care because he has already done his MD medicine. And then there is a consultant who is a DM who represents the tertiary care. So this young intern doing internship after MBBS reported for aching pain in right upper quadrant abdomen for last 3 days. He carried 16 handwritten pages of history, basically a symptom diary over last 4 or 5 years. And this was, of course, read by the senior resident, and he just summarized it for you. He also carried an ultrasound report of fatty liver disease. So after this, I have 2 questions. This is the older nomenclature of lean and non-lean and obese and non-obese NAFLD. First question I want to ask Kaushal is the new classification friendly for primary care physicians?
Yeah. So I think in terms of physicians getting acquainted to diagnosing newer cases of fatty liver, I think this is more friendly because they see patients who have hypertension and other metabolic disorders, and they just see an ultrasound, they know that this is MASLD. But I think I don't agree with the fact that it is a positive diagnosis. It is still a diagnosis of exclusion. You still have to exclude significant alcohol intake to call it pure MASLD. And you still have to exclude intake of drugs which cause this, and you still have to exclude viral hepatitis. So I think that in that term, it still creates confusion. But the primaries will be able to diagnose MASLD more frequently and more easily.
Okay. Any other opinion from the panel who doesn't agree with the partial?
Diagnosis to write would become more complex, I think. People write fatty liver just looking at the ultrasound. It's a stepwise diagnosis, depends upon its MET ALD, MAFLD, ALD or SLD with hepatitis C or any other thing. So it's a huge umbrella.
Would you ever label a chronic HCV hepatitis patient MASLD?
No, it's not that. It's the first case that you mentioned. Genotype 3 may have lot of fat accumulation in the liver. But so if you don't test for Hep C, now in this the whole big umbrella, you have to rule out other causes that are not related to alcohol or MASLD, but they may have steatotic liver disease. So for example, if a patient can be HCV positive and with a fibroscan CAP score of 350, he is HCV positive genotype 3 and has a high fibrosis steatotic liver disease. So according to the new classification, it would be a steatotic liver disease, and etiology will be a definite etiology that is given to him.
But you will be treating HCV hepatitis.
Definitely.
And you will be treating metabolic syndrome. All right. So Nitin, what is the status of lean NAFLD in patients with no cardiometabolic risk factors?
So the new classification makes it more comprehensive for lean patients to be more better evaluated and categorized. So we have etiology based, as we have been discussing, and despite the absence of risk factors also. So we will be, we have the etiology based as well as drug induced being based. We have and miscellaneous causes being evaluated for that.
So you will be classifying it as cryptogenic MASLD. All right. We'll go forward. So this is the presentation by the DM resident. 22-year-old intern has mild aching pain right upper quadrant for 3 days, developed after an alcoholic binge. He appears scared and depressed as the alcohol is forbidden in his religion. He has taken alcohol several times, regularly for past 4 years. Clinical examination shows that he is obese, BMI is 26.5, waist circumference is 38.5. Physical examination is normal except for palpable soft liver. Ultrasound shows hepatomegaly and increased echogenicity of liver, but no other abnormality. There is no history of blood transfusion, IV drug abuse, tattooing, unprotected sex. Father is obese too, but there is no family history of liver disease. He was under psychiatric treatment for 4 months before second professional examination, but he discontinued all the medicines when he started drinking alcohol. Clinically, there are no positive findings apart from central obesity. And the first question is, which subtype? Because the history is unreliable. Amit?
I think subtype-wise, you would
to help you decide, let me tell you that MASLD is less than 2 drinks a day for males, and MET ALD is more than 3 drinks a day for MET ALD. And this patient is drinking 4 to 6 drinks per day on weekends, that is twice a day, and occasionally in between comes to around 2.3 to 2.6 drinks per day.
Yeah. So if we go strictly by the definition, he fits in with MASLD. He has cardiometabolic
no, I said
factors.
The history is often unreliable.
Yes.
So where will you classify this patient?
I would still probably, so in men it is more than 3 drinks a day. He is probably giving less than 3 drinks a day. So he'll probably still be fitting into MASLD. But again, if you go through the fine print of the entire the paper which was published, it has been clearly mentioned that binge drinking is one aspect which has not been clearly covered in this definition. So we take the average consumption over a week, but we know based on the literature available that binge drinking is worse than a chronic daily intake of alcohol. And that aspect has still not been covered. So if we go by for men, it would be 33 drinks a day. He would probably be less than that. So he would fit in with a MASLD, but again, it is a continuum and he may fall into Met ALD as time goes by, and with more clarity on how binge drinking will be incorporated in this definition.
Okay. Last question in this is duration important? Because he's been drinking for 3 to 4 years.
So again, duration is important in the long-term history of the disease, but for definition, there is no clarity on that.
So would it be classified as Met ALD or MASLD?
MASLD.
MASLD. All right. Any other opinion?
So like to,
before I go forward?
so like to classify as Met ALD also.
Yeah, it's probably
One
one of the
can't hear
studies
you.
mentioned by Professor Siddiqui was 25% of patients wrongly give the history or underreport the history of alcohol, and there the hair testing probably would be more important. And this was the subgroup that felt on MASLD. So if the intern is suggesting,
So Dr.
probably few
Sanyal
other
would
tests
like to
may
say
do.
something?
Yeah, no, I think just to reiterate what's been said is that the binge drinking, even when you fall into, purely by the numbers into the MASLD, if you add these up over the course of the years, this would probably push him clinically, probably more
Met
towards
ALD.
the Met ALD.
Met
Also,
ALD.
we have to remember that the same patient, a year from now, if he stops drinking, may now be reclassified
be
because it's a very
reclassified.
dynamic person moves all over the map.
All over the
So it's not like hepatitis C that if you have hepatitis C, then you have, unless you're cured, you have hepatitis C forever. So that's how it's a different way of thinking.
Okay.
Yeah, this is a continuum where the patient can.
So, senior resident has given these differential diagnosis, and this first question we have already discussed, but the next question I want is, why there was a need to change this nomenclature again within 3 years? Gaurav,
I didn't get the questions.
why in 2020 a nomenclature was changed, and in 3 years it was again changed? So why was the need to change so rapidly after 40 years of keeping it NAFLD?
Yeah, it's probably more inclusive. As Professor Sanyal mentioned, it's the whole spectrum. It's a disease in continuum because it's a lifestyle
The
disease.
3 reasons mentioned, I'll just show you. First reason is there is a negative nomenclature which is confusing. But the rebuttal to that which people say is non-Hodgkin's lymphoma, there is no problem. We have been using that thing throughout the history.
Please repeat, sir. I didn't hear that.
The reason for second change within 3 years, I asked that question. And the reason given in the literature, whatever has been published, is that there is a negative nomenclature which is confusing and does not indicate the cause.
So 3 years back, the
But
definition
rebuttal
was
to that given is that we have been using non-Hodgkin's lymphoma for so many years, there has never been a problem.
No, so it's so just for the first part. 3 years back, the definition was MAFLD. MAFLD and not NAFLD. So MAFLD did not include alcohol. Now, as Professor Sanyal mentioned, the whole disease is a process in continuum with varying degrees of alcohol from 0 to 5 to 6 drinks per day, depending upon lot of social issues that overcome. So it's more of a lifestyle disease and disease in continuum.
Okay.
That holds for food, alcohol, exercise, stress.
So
That
you're
a
a-
person, yeah. So
you're
all
a-
these things taken into continuum may vary the severity.
Accepted you are a fan of the new classification, but some people are not. Some people said that fatty is stigmatizing. But generally we use the terms which the patients can understand because we changed CRF to CKD because chronic renal failure was changed to chronic kidney disease only because renal people didn't understand. So here we are going back on that premise.
Yeah, so fatty is
Third
stigma
reason given
is
is-
probably different for different society, different individual. Very difficult to say.
Third reason given is there is multi-billion-dollar funds committed by the drug companies for research on an entity defined as NAFLD, and MAFLD had a different definition.
Yeah, so since the disease is in continuum, we'll have various different biomarkers to assess the severity at different levels. Alcohol predominant, mixed, metabolic syndrome predominant, worsening with age, and genetic factors. So all these things were present in the society. But since we were compartmentalizing this, various aspects of this disease did not evolve.
So you are saying is that we are combining alcohol and fat today because we think that in future we'll have a common treatment for it.
Absolutely.
But if alcohol and fat both are present, you are going to treat them separately, isn't it?
No, but alcohol...
Ethanol use disorder will be treated separately and MASLD
you cannot treat that. It's good to have biomarkers to assess the severity, and according to biomarkers, guide your treatment protocols. Many new drugs, it opens a whole panorama box in which you get new biomarkers and drugs to treat.
Okay. So let's go on forward. We have very little time left. This is the investigation suggested by the senior resident. The consultant cut out the last three. Varun, in your practice, how much do you investigate a young patient who comes with NAFLD?
In a young patient in this scenario, if we have a very obvious history of alcohol and there is cardiometabolic risk profile is there. So, of course, I will go for a fibroscan to know more about his liver fibrosis and his CAP score.
You agree with the investigations?
The first one, I will definitely go about thyroid profile. I will definitely do. Viral markers, I will definitely do. HbA1c lipid profile. TTG, maybe I will skip for now. And serum ceruloplasmin can be done as a completion to rule out any other, if there is a chronicity is there.
Okay.
But alpha-1 antitrypsin and automine profile also I will may or may not do if I am very sure that it's a metabolic and meta-ALD kind of a picture.
So these are the results of the investigations. Although consultant said that last three investigations are not required, but the patient went ahead and did those investigations as well. All right. Now, does it change your diagnosis? Or is it still MET ALD?
I think these investigations does not change the clinical diagnosis of MET ALD.
Okay.
And maybe I would want to add advanced fibrosis along with that.
But when he came with investigation, there was one more development. That 16-page booklet that he had brought of symptoms was now seen by the consultant. And the consultant found there is a family history drawn there. There was, his parents were second-degree cousins. Will it account for consanguinity? Will it be defined as consanguinity or not?
Yes.
Yes, it will be defined. And the second thing that he found in those pages was the psychiatric diagnosis was writer's cramp. So would you now look differently at this patient? All right, I'll quickly go over it because time is finished. Serum ceruloplasmin in this case was normal, and there are reasons why they can be normal even in an established case of Wilson's disease. And I'll not discuss this because all of you know this very well. And 24-hour urinary copper is the test which is confirmatory. And in this case, it was 115 microgram, which is almost diagnostic of Wilson's. In addition, if the patient has anemia and gallstones, it will favor the diagnosis of Wilson's disease in a case of NAFLD, a young patient. And other features would be the psychiatric manifestations. So now, this is the second question for the audience. What will be your prescription show as a final diagnosis? Wilson disease, alcohol abuse and obesity, or SE-MALD monogenic, MASLD and alcohol abuse, MET-ALD and SE-MASLD, Wilson disease with alcohol use disorder, or MAFLD and NAFLD? Audience question, please. Dr. Chaudhary, your audience is still defined. Any comments from the, what will your prescription show? I'd like to know.
So I think I would also go with 4.
Anyone else?
2. So I would not use the new classification.
Thank you very much.
No, I'm sorry, I need to disagree with you that urine copper alone is not sufficient to diagnose Wilson's.
If the level is more than 100, it is almost diagnostic.
Agree.
I think we need more inputs also to make a diagnosis of
Anyway,
this. I agree.
the new classification is useful, but it will need further research to determine the significance of various subtypes. In the case presented, all the three diseases will need to be tackled separately, and giving a single name does not really help the patient or physician much. Thank you very much.